We're up to the next presentation, which is Dr. Dana, I hope I've got that right, Wensley from Auckland, who's going to be talking to us about research adequacy, AI, and the creation of mHealth apps. So please join me in thanking her for that. Just to let you know, we actually see the presenter view online, Dana.
Mm.
Uh,
Yes, I have tried all afternoon to get this figured out. So is this doable or not?
This
Because
this is fine. If you don't mind sharing everything, I'm okay
it's
with that because we
it's just
see everything.
seems to be beyond my capabilities, and I apologize.
That's fantastic. We still can see everything.
I
So
might.
let's go for it.
Okay, all right. So, well, thank you, everyone. Look, I want to thank Anthony, you for chairing this, and all the amazing presenters that have gone before. And this is um, going to be quite timely, I think, after Lisa's presentation, and that will be obvious, I think, towards the later slides that I have. So, yeah, my name is Dana Wensley, and I'm the Head of Research Ethics at the University of Auckland. We are one of the busiest ethics teams in New Zealand, and the University of Auckland has been named the Innovative and Entrepreneurial University of the Year in awards held in Prague in September. So we're seeing a lot of applications to do with startup creations, innovation, and teaching and research operations. And the ethics committees that I manage are seeing a lot of complex applications, I'd say, creating innovative health solutions via apps, mobile devices, and other wearables, using things like digital twins that promise to deliver improvements for patients and clinical support across a range of health outcomes. And many of those involve AI and large language models. So what I'm going to talk about today is three things. Discuss the emerging role of mHealth or mobile health apps in delivery of healthcare, review obligations of ethics committees and the creation of those apps, and with a focus on research adequacy and detecting biased and inaccurate data sets, and examine public trust and engagement with persons with lived experience. So first thing I want to show is just these snippet up here are some apps that I found off the App Store. The ones on the left are medical apps. The ones on the right are health and fitness apps. It's very hard to understand for the consumer which are which. The ones on the left here, this is called Somrest, I think is how you pronounce it. That's only available on prescription. It's available in America. It's approved by the FDA. It's gone through rigorous testing because it's a medical device. Ones down here deal with asthma and ECG. But the ones on the right are health and fitness apps, and they detect diabetes and help with suicide prevention. The health and fitness apps go through a very different regulatory pathway.
Dana, sorry to interrupt, Dana, but we're actually not seeing the slide progression. So we're all still seeing the first slide, your title slide. There we go. There's slide two, which are your aims, and there's slide three. Yep.
Is that working?
Yep, it is now.
Perfect. Okay, thank you. So thank you for telling me that. So yeah, so you can see the range of different apps that are on the market. There's in 2020 there was 35,000 apps available worldwide, and that's anticipated to grow as this becomes the new way of delivering healthcare, more personalized healthcare. So for ethics committees, it's very difficult at the initial stages to understand what is actually being applied for, because in the investigative stage, the end user is not clear to us. So from the ethics committee perspective, these are quite complex applications. So I wanted to go on and just talk about the definition of mHealth or mobile health apps. Um, they refer to a software program or a mobile device, can be available either on your phone or your tablet. The multiple terms are used interchangeably, causing confusion. That can be a health app, a medical app, a digital health app. The apps mostly focus on delivering some sort of medical information. The more specialized ones are classified as devices and go down the medical device pathway. There's, I would say, an emerging area of concern for ethics committees because there's a lack of consistency in ethical guidance, leaving some uncertainty in terms of the oversight that we have to bring. Just tell me if my slides aren't clicking through, but I think I've got it now. So I wanted to just say, why am I talking about this now? Well, obviously there's an increase in applications that we're seeing, but also there's more push towards a personalised, decentralised health system. Here's some lovely quotes from the WHO. The use of mobile and wireless technologies to support the achievement of health objectives has the potential to transform the face of health service delivery across the globe. I think that was a few years ago that quote came. The next quote is from 2018, and it's become even more obvious that this is the potential way of the future, where the quote says digital technologies have the potential to revolutionise how populations interact with national health services. They've been shown to improve the quality and coverage of care, increase access to health information, services and skills, as well as promote positive changes in health behaviours. So that's some pretty positive responses and anticipated changes in healthcare from the WHO. My interest is in the role of ethics committees in developing oversight of these with a focus on research adequacy and scientific merit. So I want to talk a little bit more about the research adequacy piece of this presentation. And by research adequacy, I mean the requirement that research design is sufficient and appropriate to answer the questions being asked. It's an integral part of the scientific validity question that every applicant is meant to answer. And how does the Ethics Committee discharge its duty in this regard? The question is addressed in our National Ethics Advisory Committee guidelines produced in 2019 and I think about to undergo a review. It puts a lot of emphasis on the peer review process. If the Ethics Committee isn't certain of anything to do with scientific validity, it's encouraged to reach out for peer review. And if there's more than a few reviews, to take the consensus of opinion. Particularly when using AI or developing AI, it's the responsibility on researchers to ensure that the source of the data, particularly with regards to quality, completeness, representativeness, and risk of bias, should be evaluated. And they must design measures to correct and mitigate the risks arising from data bias. So how does this apply to health apps? I argue that with increasing use of LLMs or large language models in the health apps, the Ethics Committee should become more cognizant of their role to either ask questions about the adequacy of the data or to seek peer review if the committee considers expert opinion is not available on the committee itself. So a little bit of a background slide about the integration of LLMs or large language models in healthcare apps. Why they're used is they're a terribly efficient way to update medical information through fast processing and extracting of medical literature. They are used to ensure data privacy and compliance with regulatory standards. They support greater patient interaction and they enhance that usability, which is a really core part of these apps by supporting chatbots where symptoms can be checked and real-time answers given. However, from the flip side, the other perspective, the WHO clearly has some concerns about the potential for inaccurate, incomplete, biased or false responses, with a concern around underrepresentation of training data and perspectives from low, middle income countries. There's difficulties in confirmatory tests or other ways to verify the accuracy, and the LLMs themselves may be biased or incorrect if trained on poor quality data. So this quote is from the latest WHO report about AI. It says most medical and health data are also biased, whether by race, ethnicity, ancestry, sex, gender, identity, or age. So I want to turn to just look at the research context in Aotearoa, New Zealand. We have some research ethics principles um, that are unique to New Zealand. They're called the Te Arotika Principles incorporated into the National Ethics Advisory Committee guidelines, and they are Māori research ethics principles involving whakapapa, mana, tika, and manaakitanga. Why this matters is because in New Zealand it's very important that our research is representative and that it engages with the Te Ao Māori perspective. And we have a very marked disparity in health outcomes for Māori compared with non-Māori across diabetes, cancer, cardiovascular disease, and asthma. So what we want to do is avoid medical apps being built on algorithms that contain biased data that can have a potentially significant effect on health. It may be very hard to detect as well, and it may have very broad impact across populations, or it may be entirely invisible for many years. So this makes it a very complex problem for ethics committees and I think the research community in general. So we also have some recognised National Ethics Advisory Committee standards in relation to social and cultural harm. I think these are very important when we consider health apps, and we need to be more aware of the question of data adequacy when considering scientific merit. We need transparent documentation, I'd argue, around diversity of data sets deployed in algorithms, with clear guidelines for ethics committees about their role in ensuring scientific merit and that the standard is met. At the moment, I would say it is far from clear. Finally, I think that the question or the way forward is probably to engage the end users in the research design. Um, some researchers do this exceedingly well, and we see this. They develop a product which is co-designed with communities that meets their needs. Those applications are very clear to read, they're well thought out, and the engagement is obvious right from the start. Those will, as the WHO suggests, be able to improve health outcomes and provide meaningful service options. But there are others that are less clearly engaged with the communities. And I think that the gold standard should be co-design and engagement with those with lived experience of the condition or disease or the community whom is the end user of the product. So my observations from here to encourage education so users become aware of the difference between a medical app and a health app and a wellbeing app, advocate for health systems to provide information and robust approval processes for apps to support public trust. There used to be a NHS website in the UK that did that exceedingly well, but I see it's not no longer being maintained. Revise pre-screening assessments, which we have done at the University of Auckland. So we're now drawing our attention very much in the pre-screening of the application stage to these issues, and asking committees to, or encouraging them to ask the hard questions around data adequacy to ensure that data used to develop and train is unbiased, representative, and incorporates all groups and end users. And finally, request peer review if unsure, especially if it is a medical health app, because those ones will have the most significant impact, I think, in terms of health outcomes for end users. So that ends my presentation, and I'm open to any questions or comments. Really looking forward to that because this is a new topic for me and one that I decided to research because it is quite complex and emerging. So thank you for listening, and just encourage anyone to reach out if you've got any ideas, questions, comments, concerns.
Thank you very much, Dana. That was great. And again, right on time. I'm just conscious that we do have the next session starting at 1. We do have one question that's been posed in terms of what are your thoughts about personalize apps when you only involve the end user, whether or not
Mm,
that's really personalized.
mm.
You got a comment on that before we
Well,
just
I guess that would be more along the line of a bespoke digital twin, which would have a lot of potential to be beneficial. I'm not sure how scalable all that is, but obviously, what we're seeing is more general design of an app because these are innovative, these have the potential to be financially very rewarding. So I'm just not sure how to answer that.
no, no worries. Again, please feel free to reach out to Dana about anything that you have. I do know there's one more about how are there any existing methodologies to create unbiased LLM?
All I know is that I did a course at MIT Sloan in America last year, and they had a lot of different methodologies that they recommended developers use. And it's a matter of designing the right one to meet the needs of what you're designing and the device you're creating. There's no one size fits all, I guess, is what I learned from that course.
Great. Just again, conscious of time. Thank you very much, Dana. Please, everybody, really appreciate your opportunity to join with us today. And please give a round of applause to all of our presenters today who gave some fantastic ideas and discussion. Enjoy the rest of your conference and move on to the next session at all. Thank you very much.